Good afternoon, everyone, and thank you for joining us. This is Debbie Plotnick for Mental Health and Systems Advocacy at Mental Health America, and it's my great pleasure to coordinate the Regional Policy Council, and this is one of our Regional Policy Council webinars, and we're delighted you could join us today. Our speakers will be Sarah Davidon, who is the Research Director for Mental Health Colorado, and Ben Harrington, who is the CEO of the Mental Health Association of East Tennessee and one of our esteemed regional policy representatives. And I'm happy to be your moderator today. And let me first begin with a couple of housekeeping slides. All of the participants in today's webinar will be in listen-only mode. The webinar is being recorded. You'll be able to listen to it later and refer back to it. A recording will be posted online for download, so you can listen to it at your convenience or share it. You'll receive an email when the slides and recordings are posted to the Mental Health America website. With respect to questions, we'd really appreciate it if you would type them into the chat box during the presentation, and we'll get to the questions and answers at the conclusion of the webinar. Very important piece of housekeeping is to thank the Regional Policy Council sponsors for 2019. That's Alkermes, Allergan, Janssen, Neurocrine Biosciences, Otsuka America Pharmaceuticals, and the Takeda Lundbeck Alliance. We want to begin by referring to Mental Health America's Before Stage 4 philosophy. This is what guides all of our work at our national office and as throughout our affiliate field. And very simply, we can state it when we, by saying when we think about cancer or heart disease or diabetes, we don't wait years to treat those conditions. We start before stage 4. We start with prevention. Mental Health America is about prevention for all, early intervention for people at risk, integrated care and treatment for those who need it, and recovery as the goal. Next slide, please. So we're going to hear a lot about today about young people. We're going to hear about kids in school. We're going to hear a lot about middle school age people. And the reason that we're starting there is because of the central question that Mental Health America has gotten some, shouldn't be surprising answers, but we have some data to back up. So what happens when people start wondering about their mental health problems? Next slide, please. They come to our website and they take a screen. We've had over 4 million screens in just under 4 years. You can see the 9 screens that are available on our website. Now, here are some surprising things. Next slide. Most of the screeners who come, again, of their own volition to take one of those 9 screens on the Mental Health America website are young people. The most popular screen is depression, but it's not the only one. And we find that 2/3 of those screeners are under age 24. But again, not surprising and very, very relevant to today's webinar is that fully 1/3 of those people are between the ages of 11 to 17. So we're talking about middle and high school age young folks. Next slide, please. And what we found from our 4 million screeners, you can see how it breaks down. Most popular is depression, as I mentioned. Then if you screen positive for depression, you're automatically kicked over to see if it's bipolar disorder, or you can go right to that. Then anxiety, and then psychosis. And you can see the further breakdown. And we also find that about 1/3 of the people who come and take a screening also have some other chronic co-occurring condition. But again, what we're going to concentrate on today is that more than 1/3 of those screeners who come of their own volition are 11 to 17. 32% are almost, again, a third, excuse me, are 18 to 24 years old. Next slide, please. And what we found from those screeners who come is that 73%, that's almost 3/4 of the folks who are coming to our site taking the screening are screening positive for the condition for which they have taken a screen, which clearly tells us that young folks know when something's going on, and they're reaching out and they're giving us the data to show those kinds of things. So I want to kick things over to Sarah Davidon, who is the Director of Research at Mental Health at Colorado, and she will be talking about their advocacy and policy. And they have a wonderful toolkit, and they have wonderful resources. Sarah?
Great, thank you very much. As you just saw, earlier on, so in the earlier ages when youth are taking these screenings, there are many of them doing this, and they're finding out things about themselves that they're then probably needing resources. And where best to access resources in childhood and young adulthood than where children and adolescents are spending most of their time. So at Mental Health Colorado, we've been working hard recently to develop and move forward a set of best practices in school mental health using advocacy and policy as levers. So as many of you may know, Mental Health Colorado focuses solely on advocacy and policy strategies, and we don't do programs. So really these advocacy and policy levers are what we see for organizationally as pretty strong ways to move forward mental health and substance use best practices in our state, and really see this as something that really could happen in any state, and it's not unique to Colorado. So as I'm sure many of you know, we have approximately 1 in 5 youth ages 13 to 18 who experience a severe mental health issue at some point. Half of all chronic mental illness, as you can see here, begins by age 14. And we also know that 3/4 occurs by age 24. However, as you know, has been reported in research and media, it can take up to 10 years lag time before youth might receive treatment. So it may be a little bit less than that in some cases, but the average has really been about 10 years lag time. So we need to make mental health screening universal. As you saw in the earlier slides around screening, when everybody has access to tools like screening tools, there's a much higher likelihood that we can start these conversations about next steps earlier on. So if we can make mental health screening tools universal, integrated into things like primary care, as well as other places where children and adolescents are, such as schools, we could be using survey instruments regularly for things like social and emotional health. We need to look at those as tools that can be used as routinely as checking blood pressure or weight or hearing or vision. So it's pretty clear that prevention and early intervention can dramatically improve mental health. So I don't think there's a lot of argument around that. And schools are places where students should be able to learn, to grow, and thrive, yet often this is a challenge. So these challenges can often be traced back to difficulties with things like social, emotional, behavioral, brain health, or psychosocial issues. So we do, know that there's a general understanding that typically mental health issues and mental illnesses have their roots in childhood, during critical periods of brain growth, particularly in adolescence. So, I think there are a number of touch points for this sort of critical period of brain growth, particularly around mental health. So certainly in early childhood. But then if we look at what's happening in adolescence, when there's physical and physiological changes that add to the chemistry of ongoing brain development, that becomes a critical touch point as well. So things like stigma and lack of recognition around mental health needs continues to remain a barrier for both, I think, adults and for children. So there's, as we know, often sort of shame or misunderstanding when there should be acceptance and support. So earlier identification and treatment for mental illness and overall promotion of mental health can really help prevent negative outcomes, particularly in school-age children and adolescents. So schools really can offer an ideal context for prevention, intervention, and positive development, and regular communication among schools and communities and families is pretty critical. So school health and student support services are also critical components of a comprehensive approach to safe and successful schools. So as we look at things like our conversations around school safety, we have to ensure that mental health is included in those conversations. So Mental Health Colorado has been working hard to make schools a priority, though we know that one teacher, one school, a district can't do it alone. So it really takes a community and it takes an organized community and school partnership to maximize the limited resources and coordinate school district and county and state agency supports to come together for collective impact and a collaborative delivery of services. So we recognize in our policy and advocacy work that mentally healthy children are more successful in school and life. So good mental health is critical to students' success. And we know that research has demonstrated that students who receive social, emotional, and mental health supports achieve better academically, as well as a number of other positive outcomes from supportive social, emotional, and mental health. So things like school climate and classroom behavior and on-task learning and student sense of connectedness and well-being all improve when their social emotional health is supported. And I want to emphasize too that that mental health, we sort of really try and prioritize mental health rather than thinking about it as simply the absence of illness. So mental health encompasses things like positive psychosocial circumstances and social, emotional, and behavioral health and the ability to cope with life's challenges and having hope and some of those things that we don't typically think about when we think about mental health in the context of prevention of illness. So left unmet, though, mental health problems certainly can be linked both financially and socially to costly negative outcomes. So identifying sort of points in child and adolescent development where we can really have sort of some significant impact, I think we continue to come back to schools. So what can schools do? So we really looked at some ways that we can recognize in our policy and advocacy work. What are some of the things that we know schools can't do alone and districts can't do alone, but that can happen if there's community, family, school partnerships in order to prevent negative outcomes. So particularly with much attention paid recently to school safety, we've been looking at school mental health supports and services as essential elements to creating and sustaining safe schools. So increased access to mental health services and supports certainly is vital to improving the physical and psychological safety of students in schools, as well as building resilience and supporting problem-solving skills in challenging situations. So what we've looked at are sort of what are some of the important things that schools can do to build the resilience of both students and schools, as well as reducing the risk of negative consequences of poor mental health. So 4 key things emerged. The first is a comprehensive approach that includes key mental health components. And what that means, and I'll go into this a little bit when I talk about our school toolkit, is that when we think about sort of an overall wellness strategy or overall health of students and staff in schools, we need to make sure that that includes key mental health components. The second is promotion of emotional well-being and connectedness. The third is identification of students at risk, and that I'll again talk a little bit more about that, but that can be through mechanisms such as universal screening. And then the fourth is having timely resources and being prepared to respond. If we do that third one, we have to make sure that that fourth element is in place in terms of having the resources and ability to respond when there are risks identified. So we developed our school mental health toolkit to help address these 4 elements with a particular focus on the first one, which is having a comprehensive approach to school mental health. So while schools certainly have many priorities in academics, we know that academic success isn't going to happen without good mental health. So this isn't a new insight that we need to address both physical and mental health concerns if schools are to function satisfactorily and if students are to learn and achieve and grow. So with the right resources, schools can be places where mental health is supported and services can be accessed. We also know that children are much more likely to access mental health supports in schools rather than if they need to drive, in some cases in rural communities, tens or hundreds in some cases of miles before they can get to their nearest provider. So while schools can't do this alone, nor should they be expected to, so we developed the toolkit to encourage community and school collaboration and referral processes to make the most of all resources. So we know that there are some school mental health best practices that evidence shows can positively impact student performance and mental health. So Mental Health Colorado, in concert with others in the field, developed a set of best practices that are based on research and focus groups and expert opinion and experience around improving the availability of mental health and substance use supports in K-12 schools. I want to mention as well that so while this is focused on K-12 schools, we have developed an early childhood mental health toolkit as well that will be available. We're hoping for Children's Mental Health Awareness Day this year that will be available on our website as well. So, this toolkit is not intended to be prescriptive. It's not a program or a curriculum, but instead the School Mental Health Toolkit, and you can see the website here where it can be accessed. It's kind of a blueprint for school mental health services and supports and can guide community members and advocates and school leaders and school districts through a set of 10 best practices, including strategies for implementing and funding and sustaining mental health supports in schools. So we developed the School Mental Health Toolkit to help school and district leadership and families and community advocates work together to support the well-being of all students, and particularly focusing on advocacy and policy strategies in order to do that. So many of our state school districts are using the toolkit as a validation framework of the practices and strategies around supporting mental health in their schools. And we see this as an exciting partnership and a model for other districts and actually other states to use as well, to sort of use the framework of the toolkit to kind of either validate some of the practices and strategies or to be used as guidance for implementation of a comprehensive approach to mental health in schools. So I want to go through the school-based mental health best practices that we, and as I mentioned, so this came from key informant interviews and focus groups and literature reviews and all of those great resources to kind of pool together what do we know really works around school-age mental health. So these best practices that we've developed, I'm going to go through. We have a set of 10 best practices. Some are able to be put in place quickly, and some might take more time, but have proved to be successful. So I'll take a few moments to give a little more detail about each of the 10 best practices and the strategies. And then I'm going to spend a couple of minutes talking about the public policies and advocacy strategies that can be used to support them. So making mental health part of an overall health and wellness, as part of overall health and wellness, I mentioned at the beginning, so we can't think about health and particularly sort of health strategies in schools around nutrition and recess and physical education without also thinking about mental health as part of that kind of comprehensive approach. The second is screening, identification, and referral systems. We know that early identification, just social emotional, I mean, we're not talking about sort of full-on assessments here, but just identifying kind of early on social emotional concerns can be both helpful at the individual student level as well as the school or program level, and looking at what might be some overall strategies that schools can use to universally support the students in their schools. The third is social and emotional learning and resilience, whether that's through a curriculum or a school or district-wide strategy to address social emotional learning that might look different depending on the size or the needs of the school. Stigma reduction, and I want to emphasize too that very rarely, if ever, does stigma reduction happen with a one-and-done training or assembly. So making sure that that's embedded into sort of overall approaches and strategies that schools have. The fifth is positive behavior interventions and supports, and emphasizing that that needs to be a part of a bigger strategy, that addressing behavior alone isn't going to get to some of the root issues. The next is school-based health centers supporting mental health. School-based health centers have proved to be pretty valuable, particularly in some of our underserved or rural communities, to have sort of on-site availability of both physical and behavioral health supports for students. And in some communities, they serve as community health centers as well and can serve others in the community other than the students. The next is partnerships with mental health professionals, really looking at those school and community partnerships so that, as I've mentioned several times now, schools aren't doing this alone, whether this is having good referral networks or sort of memoranda of understanding with community partners that might look different depending on the community. The next is teacher wellness programs and support. We can't have healthy and mentally well students if the adults that are spending a lot of time with them aren't themselves well. And the next is trauma-informed practice, ensuring that schools, and this is everybody in the schools, so bus drivers and teachers and cafeteria workers, understand, sort of have a fundamental understanding of the impact of trauma. And the last is suicide prevention initiatives. So I want to now go to kind of what has been happening around public policy. So we went through those best practices, but those aren't very useful unless we have some sustainable and embedded ways of making those a reality in our schools. So I want to go through some of the public policy and advocacy strategies that we've been both utilizing and really think are sort of have been successful both in Colorado as well as across the country in getting some of these things and these practices and strategies in place. So states have passed or currently considered legislation to impact mental health in schools, for example, New York and Virginia. And as of about 45 minutes ago, I also found out that it looks like South Carolina is on its way as well to enacting laws requiring mental health education in schools. So both New York and Virginia, and I think this applies to South Carolina as well, have a focus on implementing mental health awareness into health and physical education curriculum. In Colorado, we also have a bill moving through which requires the State Board of Education to adopt standards for elementary through secondary education for mental health and suicide prevention. Additionally, as an example of what legislation might look like to support schools, Colorado just passed legislation that's going to our governor's office now to expand a school mental health professional grant program, which would allow contracting with community providers as well as telehealth options for some of our rural communities who have professional shortages. So additionally, this grant program can be used for ancillary supports that could benefit student mental health, such as social emotional learning and discipline reduction and curriculum. Other policy strategies could include, and as I've outlined some of them here, could include looking at rule or regulatory changes that could support mental health. Additionally, presenting to local school boards and using local school boards for some decision-making around prioritization of things like social emotional learning. Also, advocacy around funding strategies that could provide new or reprioritization of existing tax revenues, such as property taxes or sales taxes, or in many states now, actually marijuana taxes and tax revenue is being used to support mental health and substance use reduction. So I want to end with some of our advocacy strategies that we've outlined in our mental health toolkit, are 6 steps to change. So to help advocates promote high-quality mental health for school-age children and youth and engage in making change, we developed our 6 steps to change tool, in which we've identified the need for both school and community support. So we're encouraging advocates to start with step 1 here. I won't read through all of these, but these are, if you go to the website, these are all in the mental health, the school mental health toolkit, so you can find the detail of this there. So these steps are intended for a wider audience than those working directly in schools. The strategies are applicable to anyone interested in championing school mental health from within or external to schools. So I wanted to mention a specific advocacy strategy that can happen anywhere. So Mental Health Colorado has built a statewide network, I should say is still building, a statewide network of advocates. We call it our Brainwave. Members of the Brainwave become an integral part of our efforts to improve mental health care by spreading the word and participating in local events. So we help them learn and the most effective ways to persuade their elected officials, to shape public policy, and to engage the news media. We also ask them to share their insights and help us identify the most pressing barriers to mental health care, as well as the most promising solutions. So we now have over 800 Brainwave members across the state who volunteer. They provide testimony at the state capitol on legislation, and they help identify on-the-ground issues. So I know my time is up and we want to move on to the next presenter, so I hope all of this has given you enough of an overview as well as some of the key specifics to understand the important role of advocacy and policy in supporting school-age child and adolescent mental health. And we are leaving time, as was mentioned earlier, at the end of our hour for questions, so I'll stop now and I will turn it over to our next presenter.
Thank you, Sarah. I'm Ben Harrington. I'm the CEO of the Mental Health Association of East Tennessee, and we've been involved with school-based outreach since fall of 2000 when we first started to build a high school-based outreach program, and eventually by 2007 we were asked to take our program to also include middle schools, and we did that in 2008, and then also in 2008 added a teacher training component that was necessary. So where to start? You can start at either one of these two locations here, either starting with training teachers and staff and parents through any of these vehicles, either mental health first aid, which is an 8-hour course, the youth mental health first aid, which is 6 hours, or through a 2-hour course through the typical or troubled program. if you start with training teachers, what I do have to counsel you is at some point you're going to want to add outreach to train students about mental health awareness and educate them about various mental health issues, because once you get some referrals from training adults, you need to sort of energize that a little bit by adding students to the equation, and you'll get a boost in your referrals that way. The same is true if you start where we did with training of students. There are a number of places across the country that do this. You'll find out we now train students in about 111 schools this year, but Santa Barbara, California, through the Mental Health America affiliate there called the Mental Wellness Center, also trains middle and high school students through a program they have called Mental Health Matters. So there are programs available that I think if you reached out to those organizations, you might be able to have some great dialogue with them and get some technical assistance to implement something. If you start with students, I'm going to warn you right now, if you raise their knowledge base and then you kind of set them on their way so that they will turn to their trusted adults for help when they need help for their friend, if they turn to a teacher that's not been trained, they're going to report back to you that they ran into a teacher that was like a deer caught in the headlights. So that's why you need to create a little bit of synergy between where you start and where you want to go to, so that, you know, if you train students, you've got to have teachers that are trained and ready to help out so they don't look like our friend the deer in the headlights. If you start with teachers and train them, you need to also add training students at some point, like New York State is doing, and Virginia and South Carolina and Colorado, so you can get more bang for your buck there and increase referrals exponentially. Okay, so if you want to implement a teacher training program, the Youth Mental Health First Aid is a place to start. Excuse me. I did say it's 6 hours in length, and basically participants in Youth Mental Health First Aid are going to increase their knowledge base so that they can readily identify signs and symptoms of who might be struggling, not coping well, prepare those folks to be able to have some sensitive and difficult conversations with a young person about either a mental health issue, a suicide behavior issue, or even an adverse experience somehow, to try to figure out who might need to be put into that referral continuum. And if they have those conversations, then they're going to decide if someone needs to be referred, and what they will be doing is encouraging that person to seek help. Now, what I want to tell you about two states, just so you can see what's going on. In Tennessee, the State Department of Education has invested some serious funds in Youth Mental Health First Aid. They have been running 3 pilot programs for 5 years, and it's been so successful. They just got the grant renewed and are now going to expand to additional counties. But what they did was they went all in on Youth Mental Health First Aid. So each of those communities is training more than 1,000 people in Youth Mental Health First Aid, and at the same time they're doing that, they embedded or co-located mental health clinicians at the middle and high school level, so that once adults in the community recognize who needs to be referred, they can be referred, and they have a place to go ahead and get treatment, like what Sarah was alluding to. There at the school, the young person is much more likely to enter treatment because it's right there. So what Tennessee is getting out of that is increased attendance, which if you're with a school district on the webinar, increased attendance equals more revenue to the school district, so that's something to keep the finance people happy. It also improves academic performance of students, and there are increased referrals. Interestingly enough, the state of Tennessee is also seeing a reduction in special education referrals, and what that's about is because they're intervening a little bit further upstream, they're intervening with children that are not at a level of impairment that requires a special ed referral and assessment. So that's important to know. The Coatesville, Pennsylvania district is really fascinating to me because they're 35 miles west of Philadelphia, and they have trained 1,400 mental health first aiders in their program, including 350 teachers in that 1,400. What's neat about this is the 350 teachers represent 71% of the teachers in the Coatesville School District. So the buy-in from leadership in the Coatesville District is pretty significant, and that means the superintendent, the principals, the school board have all bought in to this and made it so that a large number of teachers can participate in youth mental health first aid. As a result, what they're getting out of that is a very healthy 30% increase in student referrals. Now, another program that you may not have heard of is called Typical or Troubled, and I'm very familiar with this one because this one was made available to us back in the middle of the last decade when we found some kids had been turning to their trusted adults and were coming up to those deer in the headlights because the teachers weren't prepared. So this one was made available to us. It's through the American Psychiatric Association, their foundation. And Typical or Troubled is about training teachers what to recognize, who's struggling, who's not keeping their head above water, that sort of thing. And then taking that piece of information, adding to it other pieces of data that a teacher can get their hands on. Do they see the child's academic performance has changed? Do they see the child's behavior either in the classroom or in school has changed? Are they no longer running around with the circle of friends that they used to be with? Are they isolated? Are they angry, irritable, that sort of thing? Piece all those pieces of information together, and then they're able to have a conversation with a child that starts with asking open-ended questions after they've identified what the teacher has observed. So recognizable information, observable paradigm shifts in that child, and then they ask the kid what's going on. That helps that young person to engage in a little bit more conversation. The real beauty of Typical or Troubled is it focuses on the in-school referral process. And we've done this now for 10 years, and it always killed me to train a group of teachers and hear one teacher lean over to ask another teacher, hey, Debbie, did you even know we had an in-school referral process? And to hear the other person say, oh, no, I had no clue. And so that means to me that this is right on target. We've got to make sure whichever type of program you're using, Typical or Troubled or Youth Mental Health First Aid, we also talk about the referral process to make sure that child is referred appropriately, because if they're not referred appropriately, they won't get to wherever you've placed your mental health resources. So the referral process is strengthened, referrals increase significantly, and so either one of those options are evidence-based practices that are good to work with. Okay, so we started Mental Health 101 in fall of 2000. We literally had 1 week to get it off the ground before we had to go to a school to start teaching kids at the first school. So these are the major components: the stress, the good kind, the bad kind, really adverse situations, coping skills, and what are not good coping skills, of course. Symptom recognition, not only of mental illness, but suicidal behaviors, appropriate duration of symptoms requiring intervention, and teaching young people when they throw, the duration of 2 weeks or more out the window. If someone is psychotic, someone is suicidal, making comments or gestures, you don't wait 2 weeks or more just because you've noticed it today. You go straight past go, and you go straight to reach out to a trusted adult to get help. And so the other piece that we do there is we try to get young people to understand they have to turn to their trusted adults to get the help that they need. So we started in 2 schools in fall of 2000. Our claim to fame is we started at Kenny Chesney's high school. So if you're a country music fan, you'll know a little bit about that. But started at 2 schools. We had no staff to do it, so it was kind of just duties as assigned. And we had to practice and make sure we were ready. And literally from the first day, we kept getting more requests to come to another school in the district or another school in the neighboring county, that sort of thing. So we knew we had to practice what we were doing, get better at it, and start to measure some outcomes. And we measure all sorts of stuff. Not only do we keep track of, the number of total schools, the number of middle schools now, the number of high schools, number of students, but we pre- and post-test kids. And back in the last decade, we were pre- and post-testing every child, but once the program got to a unmanageable size for handling pre- and post-tests, we decided to reduce that to 1 classroom at every school we go to, so that we end up with a total sample size of about 3,000 kids that we've pre- and post-tested out of now 30,000 kids. So the program now, this year, or last year, it was in 107 schools with serving 32,000 kids. It's about equitably split between middle school and high school, and in the last 10 years, we've served about 250,000 students. The most important outcome measure I think you need to be aware of is not, number of schools we go to, number of kids we serve, or our pre- and post-test data. I think the most important thing that you need to know about is this tool called the YRBS, which stands for Youth Risk Behavior Survey. And every state in the country does a YRBS survey of high school students, and usually it's the large health departments that end up doing it locally in more urban areas. So if you've got a health department and your county is like 300,000 population or greater, go see the epidemiology staff and ask, do they administer the YRBS, and do they tabulate the county-specific data? YRBS, when our baseline was done, was horrible, but it was what it is, all right? And it gave us a baseline so we would feel validated for doing what we were doing with school-based outreach, and the schools would feel validated for doing teacher training, that sort of thing. Gave us a roadmap. We had 9 kids in every classroom in Knox County, Tennessee, who met the criteria for being diagnosed with depression. 5 kids in every classroom had contemplated suicide. 5 kids had planned a suicide, and 4 kids in every high school classroom in the district had attempted suicide. So the roadmap is clear. The data is clear. The kids are screaming for help. And so now this gives us kind of our call to action. What are we going to do about it? So if you're going to request your YRBS for the first time and start to interpret it and use it and talk publicly, your YRBS starts with kids crying for help, and the next chapters of your YRBS story are, what are you and your community going to do about it? So is there a ripple effect? We certainly believe there's a ripple effect. When 2007 came along, we'd had the first YRBS after our baseline. Things started to look better, and the school system said, hey, can you do this in middle school too? So that's one ripple. Another ripple is when they're asking for that, I had to ask for something back, and that was I had to ask for schools to let us do teacher training because we were running into some deer in the headlights situation. So they asked us to do something, I asked them to do something, and then we worked together to help raise the money to be able to do it. And so the ripple effect, as you can imagine, when you start training middle school students on top of training high school students, our program doubled in size. And then when we started training teachers, that just grew and grew and grew. So today we're at 265,000 students trained from fall 2000 to the end of March, and we've trained 3,000 teachers. So there should be some ripple effects. So what have we got? We've got obviously the number of schools has increased from 2 to 107 last year, and it's actually going to be at 111 this year. The number of students has changed from, I think, 450 kids the first fall of 2000, and now we're at about 32,455 last year, and this year will probably be very similar. We know from our pre- and post-test that the students' knowledge base is going to change and change dramatically. And I'll tell you this, if you have a teenager, you know they think they know everything, so we ask a real simple question on a pretest. Do you know the signs and symptoms of mental illness? And this is your cast your bait in the water type of question. Every kid will answer that question, yes, I do. So the follow-up question is a demonstration question. List 3 symptoms. And only 20% could list symptoms when we first started asking the demonstration question in our pre- and post-test. So it's significant. We can move kids from 20% can demonstrate symptom knowledge on a pretest to more than 85% on a post-test. So that's the sort of thing that's supposed to change when you have a program where you're educating students, and then when you add referring or training teachers, you're going to get referrals, and some of these referrals are also going to come because students, also refer their friends, their peers, who they are worried about. If they see someone is struggling and not coping well, students are going to self-refer too. So we're seeing the things change for the good that are supposed to happen. Now let's talk about any decreases that we're seeing. And the answer is, yes, we are seeing decreases, and we've seen them over a period of time. Our baseline was 2005. The first YRBS iteration afterwards was 2007, and things looked good based on that 2007 YRBS assessment. But the public health folks cast a pretty good warning, and it stuck because I've learned to preach it. You can't just get excited after one new YRBS cycle. You have to let this go for a number of years, and you have to see, do you have change over a longer period of time? And so what we've got here at the bottom of this slide is 10-year data. So 5 YRBS cycles that shows what we wanted to go down is going down. So the percent of kids that met the criteria for being diagnosed with depression has fallen 11%. The kids contemplating suicide has gone down 20%. Students planning suicide has fallen 25%. And the percent of kids who actually attempted suicide in the prior year has fallen 50%. That's exactly what we were looking for, but of course we had to let this play out over 5 YRBS cycles to see if we could get that. Now another indicator is the bottom thing on this slide. 4 out of the last 8 years, Knox County schools, or Knox County, Tennessee, which is the 3rd largest school district in the state, has had 0 suicides 4 of the last 8 years. So we think there's a good ripple effect. We think 10 years of now positive change driving suicidality downward is impactful, and we think what's helped is training all those teachers, the 3,000 teachers, training 265,000 kids has been helpful in keeping that ripple effect going. But you see all these things going up that are supposed to go up. You see the things going down that you really want to go down. We had to ask ourselves one more question. Are there any other indicators that this is making a difference? And the answer to the question is yes, because schools weighed in with us to leverage the community to do something to add more mental health professionals at the community practice level, community mental health center level, and now in this current decade we've had a number of counties partner with, contract with community mental health centers to embed staff in their schools. So those are two more indicators. But the last indicator tells the whole story and gives us the goosebump moment when we tell it. In Knox County, Tennessee, the county with the most teachers trained and the most kids served, all right, we've had a 453% increase. A 453% increase in kids entering treatment since 2008, which is when we started middle schools and when we started teacher training. So I think that kind of indicates the ripple effect did what it was supposed to do, get people the help that they needed so that they could enter treatment and live healthier lives. Thank you all.
Thank you, Ben. Thank you, Sarah. Questions, if you have them, please type them into the chat box. We have one question, Ben. It's a clarification. Several people have asked about the mental health first aid course, saying they know it to be an 8-hour course and wanted to know if it was being piloted as 6-hour in Tennessee or if it was, in fact, that 8 hours as in other states.
Well, you know, Debbie, I think I have to say I'm not quite sure, because what I saw in a lot of places online was 8 hours, and then I saw one site offering it as a 6-hour course.
Very good. We will look to qualify that, but it may be a little bit different, and as our questioners had put in, they wanted to know. Here's another question. The question asks about any issues in educating school counselors and other professional staff about the financial liability of the school paying for mental health services. The person asking the question has experienced some barriers of referrals being sent outside the school. Somehow the school district feels that if they send them outside, they might be responsible to pay for psychological or psychiatric services.
Debbie, I think that's a good question. I think one thing that a school district could do to try to get past that, they could either hire their own clinical staff and put them in the school buildings and then try to bill their Medicaid or their commercial insurance themselves, but that's going to be a long road to go through, or they could make quicker work of that and partner with a community mental health center to embed staff, and then they don't have to go through the hurdle of are they going to end up paying for it, because the mental health center could bill Medicaid for services in a school building and could also bill commercial insurance for services in a school building.
And that's
Sarah. Been the experience. Oh, I'm sorry, Sarah, go ahead.
Oh, no, that's okay. I would also just add on to that sometimes a very simple memorandum of understanding could help resolve that. And just, I mean, if anybody needs samples, happy for folks to contact me directly. But that sometimes is a very simple solution to what people fear is a complex problem.
Thank you, Sarah. And our experience across the country has been, as Ben said, many school districts just directly bill Medicaid, and depending on the percentage of young folks in the school who are on Medicaid, that usually takes care of it, and some of them are willing to work with private as well. And please do contact Sarah. You can see her contact information for that sample memorandum of understanding. Thank you so much about that. I see another person has said that mental health first aid training in their state, which is Alabama, is 8 hours. So perhaps that is the standard, and we can double check on that for youth first aid. We'll double check on that with America Paredes at our national office, who is a certified trainer of mental health first aid, and we will clarify that for you. I'm not seeing any more questions, and we're coming up on 2 o'clock. I'm going to remind everybody that you'll receive an email telling you the slides and the recording are posted, and you can feel free to contact Sarah and Ben with additional questions. I also would like to remind you that Ben is going to be talking about this particular topic in much more detail at our pre-conference, right before our conference. And Ben is going to really get into the financing issues. So I hope you'll all be attending our annual conference, Dueling Diagnoses. And the pre-conference day is June 11th. I hope I have that right. Do I have that right, Karen? I'm not looking at the calendar.
It's June 12th. That's Wednesday, June 12th.
Thank you. Because we have our Policy Institute June 11th. That's why it's stuck in my head. And we hope you'll come to that as well. But the pre-con will be the June 12th. And among the sessions will be Ben's, and he'll be there to answer questions for you in person and to really get into the mechanics. And I believe Sarah's also going to be attending the conference, so you can catch up with her as well. And Mo Keller from Mental Health Colorado, who works with Sarah, who's one of our regional policy representatives, will also be there to talk about the terrific things going on in Colorado as well. So we are just about out of time, and I see lots of thank yous coming up in our chat box, but no more questions. So I'm going to say thank you to all of you for joining us today.
Thank you.
Thank you, Karen.
Thank you. Is this recording?
Somebody's got to let me control the...
Oh.
You can be able to take it back.
That was me.